It's always nice to introduce someone who spent time working for the government and working for a big pharmaceutical company. Some similarities and a lot of differences. I can certainly know that from experience, but I don't think she's going to tell you about that. She's going to tell you about some other things, so welcome, and nice to have you here.
Thank you so much. It really is a privilege to be here, and I, of course, thank the Larrys and Meredith in particular for their incredible challenge of pulling this symposium together, and everyone who's just made it such an incredible event. I think, well, for me personally, just getting out of the vertical world and really immersing in this more horizontal engagement with science, but also the context in which it's created and utilized and challenged, it's a privilege. So thank you for that. I want to start also by being transparent in the spirit of trust about some of the other activities that potentially create conflicts of interest. But when I was thinking about this in the context of my day job, which is to serve the foundation for the NIH, I really sit at the juxtaposition of the incredible scientists at the NIH, as well as their counterparts in industry, in academia, in patient organizations, patient research organizations, and foundations. And from that vantage point of kind of being an orchestra conductor of team science, I really realize how amazing the world of science is today. I like to say science is truly on our side, but I also recognize that sometimes society is struggling. And you heard Tom this morning talk about trust in science declining over time, and I think that really is a framework that allowed me, when I thought about it, to pull together a framework for trust, what's happening to it, what's detracting from trust, and what we need to do to rebuild it. Now, it is true that trust in institutions has been declining since at least 1979, when the Gallup started measuring it. Trust in institutions that are listed on the bottom of this slide in 1979 did not include health and healthcare. Apparently there was not a concern about those institutions at that point in time. So those organizations are not reflected in these data. But I point this trend out because sometimes people think that the absence of trust or the erosion of trust has to do with the internet or with social media. And just to say that there's a larger societal context for this. But the University of Chicago did look at trust in medicine, medicine decision makers, and so forth. And you can see the same time trend, the same decline in trust, but you can also see the difference between the Republicans and the Democrats on this slide. Interestingly, historically, Republicans had more trust in medicine and medicine decision makers, but around the time of the pandemic, that flipped. And if you follow that forward through other surveys, you will see a tremendous politicalization of the trust in science, and a point I'll come back to in a second. So this erosion of trust has been a topic in medical circles for at least 20 years. This keynote speech from the president of the American Heart Association in 2004 really pointed out that it's serious. Lives are at stake. It really matters whether people can trust medical decisions, medical advice, and are willing to follow them. That really fast forward into the last couple of years when some of the leaders of our health systems have really said that the leading cause of death in America is mistrust in our health system, because people are not following the advice and they don't have confidence in the science that underpins it. So we do have to really take a look at this erosion of science. And what I want to try to do in the next few minutes is accomplish three things. One is to point out with some detail how this trust factor plays out across the pipeline of health decisions. Second, to make a case that really came more to the forefront of my thinking yesterday when we were talking about dehumanization and social determinants of health, that beliefs are really a social determinant of health, and I'll explain why I think that's the case. And then finally, to spend a few minutes on what can we do. We're presumably fairly influential people by virtue of the fact that we're participating in this symposium. This is not something we should stand by and watch. This is something that we should participate in addressing and hopefully trying to correct. So this graphic really illustrates my sort of personal view of the health pipeline. It is not the pipeline of drug discovery where you have phase 1, phase 2, phase 3, phase 4. This is the pipeline of how the tools we have in medicine, the knowledge and the science that we have in medicine gets translated into health behaviors, actions, policy decisions, et cetera. I'm going to spend time mostly on the first 3 boxes here, but I also will just acknowledge up front that trust in our health system, on the ability for people to access affordable quality care, and then their own self-agency and their motivation and capability of acting on that information are also important features. But let's start with the availability of the science per se. On the right-hand slide here are all of the elements, or some of the important elements that really go into the trustworthiness of scientific information that underpins health decisions. Obviously, we need the discovery of new scientific insights and the translation of them into tools, but we also need to be able to move that science into relevant recommendations and guidelines to create standards of care, and very importantly, especially in light of our last lecture, to make sure that the applicability of that data is relevant to the populations of people that we're aiming to influence and affect with it. Now, trustworthiness of scientific evidence is a bit under siege, and some of that is self-inflicted. This left-hand part of the slide here was an article in Wall Street Journal, I think last week, that described terrible incidents of scientific fraud by the publication of fake journal articles. And 4 different journals published by Wiley had to be completely pulled out of publication. 11,000 articles were removed. So we're seeing, in part because of AI and bots, et cetera, we're seeing an undermining of the tradition of careful scientific peer review and the ability to have confidence in the published literature. The center graphic here is just a re-emphasis of the inclusion of various populations of people in clinical trials. Always white people are overrepresented in clinical trials compared to their geographic and country distribution, but racial and ethnic minorities are underrepresented. And this becomes important as we think about artificial intelligence and its utility in medicine, because if we put biased data into the system, the algorithms by definition are likely to be biased, and we get biased outcomes from that. And the problem with the AI algorithms is it really is a black box. So if we're not sensitive to the quality of the data going in, we have really very limited ability to understand and interpret the neural networks or the techniques that are used to derive the output. So that has to be addressed. But I think the bigger issue here is really that people do not understand the process of science. We play out a lot of scientific controversies now in the public domain, and people get confused. Should we drink red wine or not drink red wine? Should we eat bacon, not eat bacon? You know, these things are bombarding us on a day-to-day basis. So there's a lack of understanding that science is really built on controversy. That's how we arrive at truths. That's how we build consensus. We have debate, we have argument, sometimes we have competition, but in general, through the team effort, the collaboration of the Society of Scientists, we arrive at truth, we test it, we update it when we learn something new, and eventually science progresses. This is a very different process than one that is referred to as polemic. A polemic is when people ideologically twist information or data to serve an economic or a political aim. And I think we can all recognize that polemics are at play in our society today in many ways. We could talk about climate change, we could talk about vaccination. There are many domains where this hyper-mediatized war of documents are pulled together by people who have a non-scientific or a non-health related agenda. have never heard of the word obscurantism, but it seemed like it was a fitting description of the intent to obscure truthful science and to utilize it for nefarious aims. One representation of this that Tom referred to this morning really refers to the politicalization of all of the issues that played out during the pandemic. On this graphic, the blue dots over here represent states or territories where there were high vaccination rates and lower COVID death rates. The red dots represent states where there were lower vaccination rates and higher per capita death rates. That's tragic. People died because of the distortion of information and the misinformation that was promulgated during the pandemic. Because I don't have a book, I haven't written a book, but we are dealing with book club, I wanted to just mention 2 books that if you're interested in this whole process of polemics and propaganda and how it's playing out in very scary ways, to read The Constitution of Knowledge. It's hard to read, but it does evolve into a more hopeful framework. And then the Trust in Science book is a bit of an older book, but it talks about the history of knowledge acquisition, and some of the reasons why trust in science has been a challenge in recent years. So let's move to the next box here, which is really about accessibility. I'm not talking here about accessibility to care. I'm talking about accessibility of the information and the science that's created. Again, Tom this morning did a brilliant job of discussing how jargon interferes with the accessibility of science, but there are some other dimensions of this that are important too. Let me start with just a simple cartoon of health communication from a traditional point of view, what I was taught when I was a medical student, that you have some experts over here who have the information, the knowledge, and they have to translate that to the patient or to the community of people who need that information in order to make good health decisions. So the hypothesis is if you have great information and you have people who are health literate and have good numeracy, that you will end up with good health decisions and behaviors. If only it was that simple. Obviously, this is a naive presentation. For one thing, people are imperfect, and numeracy and health literacy in the United States is really bad. We are dealing with a population right now where about 40% of Americans believe in creationism, meaning that human beings are evolved on Earth 10,000 years ago, or were put on Earth 10,000 years ago, including some former vice presidents of the United States. So we have a dynamic going on here where our literacy and our ability to take in scientific information is limited. But we also struggle with innumeracy, just really hard for people to understand numbers, particularly when they're not well presented. I just love this particular infographic, which almost anyone would struggle to interpret these different frames for the value of screening, mammography, and what needs to be done to reduce breast cancer among women. You really have to have, high numeracy to be able to interpret something like this. So that brings back the other side of the equation. It's not just the recipient of the expertise, it's the transmitter of the expertise that is challenged. And too often we use jargon, we use numbers, we use frames for information that are just beyond the comprehension of even educated patients. And I think one really important dimension of this that I've certainly learned in my experience is knowing who your audience is. You really have to understand the person, their family, their community, their culture in order to be an effective communicator. This hit home for me at Merck when we had assembled a lot of women to discuss the importance of screening for breast cancer. And we had pink ribbons all over the auditorium because that, of course, is the ribbon for breast cancer. Well, it may be the ribbon for certain breast cancers, but we had a disproportionate number of people in the audience who were women with triple-negative breast cancer. They see that as a very different disease. It's much more aggressive. It has the worst prognosis, differentially affects African American women, and they have a different ribbon, as do all of these people. So to even use something as trivial as a symbol of what you're trying to communicate is not very helpful if you're not really respecting where your audience is coming from. Now I'm going to take this up a notch to critical communication, high-risk communication, as we saw during the pandemic. I have read all of the transcripts of the White House press briefings that I could get my hands on. I don't have a claim to have read every single one of them, but I was particularly interested in how the health officials who were speaking to the American public introduced their topic to their audience. And these are just the first sentences from many different press conferences, not just in the Trump administration, also in the Biden administration. So this is a mix. And what you can see here is almost inevitably the start of the conversation was about data, often complemented with complex charts and graphics, numbers of cases, numbers of hospital proportions of vaccine people, and so on and so forth. This is not the way to bring a people together to understand what's going on in the context of a crisis. It is devoid of the human elements that allow for effective communication. And a number of years ago, after the first SARS pandemic or epidemic in the world in 2003, the CDC put together a curriculum on how to do this well. Apparently nobody read it in 2020, but it really builds on the principles of effective crisis communication. And when I read through these transcripts, I tried to identify where was there an A+ rating and where was an F- rating. So the red X's here really represent places where I really found very little evidence that those principles of effective communication had been utilized in the context of the risk communication. And really the most important principle was empathy. You really have to look hard to find expressions of, boy, this is really hard. People are really struggling to isolate. It's scary not knowing for sure if you should trust these vaccines. There was really no conversation, at least from the federal level. Now, if you go to the state and local community level, you'll find much better examples. And I don't criticize my colleagues at CDC or NIH or elsewhere because these White House press conferences are scripted. I'm sure they were told, your job is to go in and present the data. But in doing so, they lost the opportunity to build trust and to really help people understand what we were up against, that we were all in it together, and that we needed to work on it collectively. So there is a lot to be said and a lot to be learned about how to build trustworthy communication. And as practitioners of that, I think we need a little more science and a little more evidence, but also a lot more education and training in this regard. So let's then move to a really huge issue in all of this trust, and that has to do with the infodemic of misinformation and disinformation that clouds the world for everyone who's trying to deal with decision-making in the health space. Very soon after his appointment in the Biden administration, the Surgeon General came out with a really interesting toolkit on how to combat misinformation. It's very practical. It's not written for elites. It's written for everyone. So if you want to look into that, I would suggest you pick it up off the internet. But this did also cause me to expand that traditional model of health communication a bit to allow for the fact that our non-experts who are receiving health information are getting a lot of information, often bad information, from a whole lot of other sources than their care provider. So the theory would be if we could correct all this bad information or minimize it, that again, we would end up with better decisions. And there may be some truth in that, but it overlooks one really important element. This is just a little case history of a guy who works as a healthcare worker who graduated from college. Actually, this is a different case. This is a case of a mother who has 2 teenagers. She lives in a rural community and is a college graduate. She works as a healthcare worker. She's at really high personal risk because of her own comorbidities for severe COVID. She refused to be vaccinated and refused to vaccinate her family. Now, she's pretty savvy at interpreting medical information. She's pretty smart about what's bad information and what's good information. So it isn't so much that she can't discern the reliability of the source. The issue for her was she had a different lived experience. Her son survived severe Guillain-Barré syndrome and was paralyzed for quite a while and hospitalized for many, many weeks. And when he was better and discharged from the hospital, the doctor said, "You should never be vaccinated." So her belief is that vaccination is what caused her son to suffer this serious paralyzing medical condition. And there is nothing that's going to shake her belief in that causal association, even though I don't believe the causal association applied to the decision she was making. But it just really brought home to me the importance that belief systems have in how people process information. That in this world, medical decisions are not driven by the experts. They're driven by the recipient who has pre-existing beliefs and lived experiences and attitudes and social circumstances. And there isn't so much an erosion of trust as a misplacement of trust, or I would say a displacement of trust toward the peer group or the internet or the social media that's bringing in all of this other information. So there's trust. It's just not trust in institutions or trust in experts in the way that it used to be. And we need to understand these belief systems because they are very powerful determinants of people's health decisions. And that's why I say that beliefs really should be regarded as social determinant, and we should query beliefs and understand them and listen and really learn how our patients or our communities of people we're trying to influence respond to this. Now, given all this input of cognitive information, none of us, even experts, cannot possibly logically process all of these claims or all of this advice. So, because we're humans, we take shortcuts. From a behavioral economic perspective, we make emotional decisions that really quickly check out, is what I'm hearing consistent with what I already believe or think I know? And if it's consistent, I'll buy it. If it's coming from someone I trust, like my best friend or my neighbor, I'll buy it. It just takes too much effort to do a literature search every time we hear a new idea or a new recommendation. So that logical, rational brain is not the main tool that many people utilize to make these decisions. And we need to understand this and work with it when we are trying to influence people's decisions. It isn't what people know, it's what they already believe and who they trust. So in terms of building trustworthiness in this domain, we have to realize that the default is to make a belief system that's concordant with what you already believe, that you look for trusted sources, and if you can, and you're trying to influence in this space, use trusted sources who are informed. And that's why so much of the success in certain communities in getting people vaccinated against COVID was to utilize local experts, people who looked like the expert, people who were familiar with the community and the culture and were trusted because their perspective was consistent. Like, I'm hearing this from someone like me. So I go back to this pipeline, and as I said, I'm not going to have time to talk about the last two boxes here, but I think to make this into a short story, we could really think about this as a trust pipeline, because trust matters in every single one of these steps, and trust has been eroded or displaced in every single one of these steps. And if we really want to move the needle on the dial and take advantage of the incredible science and the science tools that we are creating, we have to deal with this underlying issue, which is not getting any better. So what are some of the things that can be done? Well, first of all, be trustworthy. I'll just put that out there. And that means tell the truth, be transparent, and be an exemplar of walking your talk. So I'll just start with that. But there are things that we can do to push back on information. And again, the Surgeon General's publication includes some of these. But one of the most important principles is don't shame people for how they see the world. You said this morning, you said listen first. And I don't see it that way, or tell me how you see it. I'm not sure I agree with you, but really create a framework. The other point, which we just heard brilliantly in our last lecture, is the importance of stories. If you want to teach your teenage kid not to text and drive, you don't get a PowerPoint presentation out and show them the data. You tell them the story about some tragic situation where someone was texting and driving and had a terrible accident. So you use the emotional power of stories to help people understand things in terms that their emotional brain, which is where they're making decisions, can relate to. That's usually not a PowerPoint. There are also ways of really confronting misinformation and disinformation. And again, not to go into the details of these, but the science here is building. There is now a compendium of the research and some meta-analyses that are coming out to help people understand what does and does not work. But at the very least, help flatten the misinformation curve. Don't pass this stuff along, even if it's funny or exciting or tantalizing. It just adds to the noise and makes it harder for people to sort things out. Some of the very specific tools that are now being used, and hopefully maybe some of our social media platforms are learning from these, are how we can identify and flag information that's inaccurate, how we can actively intervene to debunk bad information when it's out there, but most importantly, and probably most powerfully, how we can learn to pre-bunk information. Think of pre-bunking like a vaccine. You anticipate that there's going to be a misinformation challenge. We're going to put out a new H5N1 vaccine. Let's anticipate what the response to that would be, and then help people learn the tactics that are used to promulgate misinformation, to be on the lookout for these kinds of techniques. All of the things, my favorite one is the false balance, when you turn on the TV and there's some Nobel Prize winning scientist next to some crazy person, and they treat them as if their points of view and their information was equally valid. That false balance is a fantastic tool for creating controversy and selling television ads, but not so good in helping people get a balanced view of what's going on. There are real tools for pre-bunking, passive tools where you just send stuff around the internet, but increasingly games. So games have really become a very popular method for debunking. And then lastly is an invitation to participate in something that we're calling the Coalition for Trust in Health and Science, which is a coalition of now more than 100 organizations, including most professional associations of health professionals, patient organizations, public health people, et cetera, who are coming together to do three things. One is to describe what they're doing about misinformation and disinformation. So instead of Brownian motion of a lot of little things happening, we may be able to work together and move the needle on the dial. The second is to define the research agenda and the compendium of work that needs to be done so that we can bring some science to bear on what we do, I think, agree is a very serious health problem in the United States. And then lastly is to learn to effectively push back as people, but also as organizations, because collectively now there are hundreds of thousands of people represented in these organizations that are part of the coalition. And if we would all participate in the conversation, there are a lot more of us and many, in most cases, than the people who are creating misinformation and sharing it. We just don't participate. So we need to take some accountability and some responsibility to get out there and communicate the reliable information that we have. So I try to cover these three objectives, and I'm happy to take questions. Thank you.
So we have one there.
Thank you very much, Dr. Gerberding. Chris Lundy is my name. The Hippocratic Oath is not, for medicine, is not really the touchstone, I would imagine, for how to prevent maybe or to stop misinformation, disinformation. Yesterday with Dana Matthew, I kind of brought up ethics. I was just wondering, is there like some sort of touchstone that you in the business or the field might go to try to help prevent this mis or disinformation? I know in intelligence business, that's their stock and trade is mis and disinformation, but obviously we don't want it here. So thank you very much.
Yeah, so when I said be trustworthy, I think this is a conversation that's coming up in a lot of environments. The naive thing is, well, I tell the truth. Why don't you trust me? But I think increasingly, as representatives, at least of the medical profession, we have to also realize that we have to walk our talk. And we have to be exemplars. We have to be role models of the good health and the good health decisions that we're trying to promote. But we also need to be transparent about where our potential conflicts of interest come from, et cetera. So it's not just about what organizations you belong to, but who funds you, where does your money come from, what are your alliances. Bringing out the full picture of our own perspectives is an important aspect of medical ethics. And we could have a whole other talk about scientific misconduct and fraud and the complexities of that now in the world of AI and the ability to manipulate data. But I think there's a lot more to be done in that space.
So just before we go to something back, I'd like to see, are there any questions from the online? Larry, do you want to ask one of those first? And while you're doing that, I'm going to ask you a question about risk assessment. How well do you think humans understand the concept of absolute risk and relative risk?
I think it's terrible.
And how do we change that perspective? Because it hinges on a lot of what you're saying.
Yes, I didn't include in this particular presentation a wonderful tool from the Mayo Clinic that helps people make decisions about whether they should take a statin for their cholesterol or not. So you can put in your risk information, and it's a lovely graphic, and it basically says if you have 100 people and you don't take a statin with this particular risk configuration, 11 people are going to die of a heart attack in 10 years. If you take a statin, 4 of those deaths will not occur. So that's a presentation of absolute risk versus relative risk. So depending on how you frame that, does your risk go from 11 out of 100 to 4 out of 100, or is it an X% reduction in death rate? You'll get different decisions from patients. And that's the kind of conversation that requires participatory interaction of the clinician and the patient to really get to that.
Okay, good. Good answer. Where did we have one? I thought there was one at the back.
Tim,
yes,
I
there you
don't
go.
have anything online, but I have a question, so I'm going to ask.
Okay, you ask it, Larry. Then we'll go to the guy in the white shirt there.
Okay, great. So, Julie, this is inspiring and terrifying, and I appreciate the work that you've been doing around it, but I think you didn't mention 2 important elephants that we ought to talk about, and one of them is power and the other one is technology. And so until fairly recently, we didn't have a good way of measuring whether advertisements work. And so it was really hard to come up with messages that persuaded people to action. But in the modern era, last decade and a little change, we now have extremely good evidence about things that work. We can do A/B testing at ridiculous scales and really manipulate that technology in order to drive behavior. And mostly it's driving people to buy consumer goods, but it also is used for other purposes. And I'd like to hear your take on what the technology, what role it plays in this. And related to that is there are some very powerful actors who use those kinds of technologies to advance their ends. And I'm not thinking just nation states, although that's clearly important, but billionaires as well. And you can see that kind of power, for example, in the purchase of Twitter and the change that happened as a result, which is clearly driving one person's agenda, happens to be a very rich person. So will you talk just a little bit about the roles of technology and power and misinformation?
There's no question that this is, I believe, in a hyper-log phase where we're going to see more and more impact. The book that I referenced at the beginning for book club really addresses this issue in great detail, and that's why I had trouble reading it, because it's really scary. As you said, it's really frightening to think about how powerful that approach to propaganda and manipulation really is, and I do characterize it as propaganda. That is probably one of those places where regulations and government need to play a role. There have been some attempts, National Academy of Medicine, trying to come up with what constitutes ethical behavior in this space, but there's no sanction, no ability to enforce what people are doing. So I think it's very frightening, and I don't have an answer.
Up the back there behind, yeah.
Hi, very good talk. So I was wondering if you had an opinion if it's kind of a dual approach from, defunding education and scientific literacy, like if this was something that was kind of brewing for years because of the defunding of education, that creates then the polemic or gives it a better effect. Could you give any comment to that?
I don't know the answer to that, but I think it was in 2010, actually before 2010, but the last time it was really advertised, there was a national strategy for health literacy or scientific, I think it was health literacy, and it made a big splash, but there was no funding and nothing really carried through into the schools. So I think it is very problematic.
Okay, we've got one at the back and then one at the side, and then we're going to draw it to a conclusion, I think.
Hi, how do you do? Julie, Mark Messenbaugh with SomaLogic Standard Biotools. We are members. I'm back here.
It's up at the back there, you can't
We're
see.
actually members of your organization, the Foundation for the NIH, a wonderful gathering for public-private research projects that advance both common understandings of disease and biomarker tools to advance drug development. I'd love to hear you comment on what role that gathering might be able to play in the agenda you just laid out.
Well, Dr. Collins, the former director of the NIH, spoke at our annual fundraising dinner for the Foundation for the NIH, and it was my first event, and I was brand new in my role, and in this very public forum, he challenged me to take on the issue of trust. And what can we do as scientists, what can we do as conveners of such a broad part of the health ecosystem? And so the coalition is one outcome of that together with Sudip Parikh from AAAS, Murray Woolley from Research America, Bill Novelli, formerly AARP, and Porter Novelli, PR and Reed Texan, who's really led the effort, who's a very prominent African-American physician and a champion of humanizing medicine. We just got together and said, let's do something, let's get started. And so we created that nonprofit and are working through it. And I'm hoping that as the research agenda matures, that we will be able to find people willing to invest in supporting the science here. It's a kind of an orphan domain right now. There's no one who's really, no institute at NIH is such a cross-cutting issue. No specific foundation, although a couple of foundations have provided us some startup money to at least bring a leader on board to get us going. But we're aiming to build a viable partnership in this space, and that's the purpose of assembling the wise crowd. So love to talk with you. Perhaps you'd like to be involved in that.
Okay, last one. We have a last question there, and then we're going to wrap it up.
Julie, great talk. We'll have another pandemic at some point. I think there's something we never quite worked through from the last one. And it's about this relationship between science and political leadership. We saw examples in the UK, but here also in the US, where the scientists wanted to close ranks, even though they weren't sure. So you would have the chief scientific officer standing up and making very firm statements that he didn't, in fact, have the scientific basis for to the level that he would have liked. And so how do you deal with the genuine uncertainty, whether it's about where did the virus come from, or what's the likely side effect profile of a new vaccine? How do you deal with the fact that there is genuine uncertainty, but a great desire on the part of the scientific establishment to support political action?
Thank you. I really struggled with this when I was a CDC director. You know, even in SARS-1, there was enormous uncertainty. And I learned very quickly from the people who were helping me that it's a myth that people can't tolerate uncertainty. It's a myth that by telling people the truth, that they're so frightened that they'll panic. That never happens. People respond to truth-telling. They know that there's uncertainty. They know that it's frightening. They are not fooled by politicians or scientists who offer false reassurances. So I think it's not just the scientific community that creates artificial certainty, it's the political community that creates artificial certainty. And it's hard to say, I wish we had an answer to this, we're working on it, here's what we're doing to find out, but you know, this is what we know today, and we're gonna meet with you again tomorrow and give you an update. It is really, but you know, if you look at that checklist of crisis communication, acknowledging uncertainty is on that list, yeah.
Great,
So
well,
thank you.
thank you.